Okay, good morning, everyone. Very nice Monday morning again. And we will discuss very important topic every day, almost every day, at least twice in a day. People ask about whether I should give water, how should give water to my patient. He's not eating, he's not drinking. So regarding drinking, what exactly we should tell when patient is almost in the terminal stage? It will be taken up by team MNJ Institute of Oncology at Hyderabad, and this will be moderated by Dr. Gayatri. We all know the Gayatri very well. So I request Dr. Gayatri to please introduce our young new DNB student and please start. And everybody, I ask that please, I request that everybody should write their question and answer in the chat box. Dr. Gayatri will take up at the end one by one. So I request everyone, please, write down questions. And then the newcomers, those who are not knowing Dr. Gayatri well, there are many people have joined recently in 1 month back. So Dr. Gayatri is professor and heading the Department of Palliative Medicine at MNJ Institute of Oncology, Hyderabad. She is also consultant of Two Worlds Cancer Collaboration Canada. She is also board of trustee International Children's Palliative Care Network. She is also founder and executive committee members of Pain Relief and Palliative Care Society. She is one of our brilliant national faculty of Indian Association of Palliative Care, and she is also working very diligently as an editorial board in Indian Journal of Palliative Care and Journal of Palliative Medicine. So Gayatri, please go ahead. Thank you.
Good morning, and thank you very much, Dr. Bhatnagar, for the kind introduction, and very good morning to all of you. So with great pleasure, I introduce Dr. Ritabrata Bandyopadhyay. He's actually he's getting into second year now, a very compassionate and very kind, very brilliant palliative care doctor. Over to you, Dr. Rito. We call him lovingly Rito, easy to pronounce. Over to you, Dr. Rito.
Good morning, everyone. Good morning, ma'am. I'm Dr. Ritabrata Bandyopadhyay. I'm from West Bengal, and I'm doing currently my first year DNB residency in MNJ Cancer Institute in Palliative Medicine. So, good morning, everyone. So, today we are going to discuss about the topic rehydration in terminal and palliative care. Yes or no? So first, the contents, we are going to discuss about some cases, the introduction, some terminologies, dehydration in terminal and palliative care, rehydration techniques for palliative care, benefits of dehydration, risks of dehydration, decision-making process, ethical considerations and controversies, hydration-defined studies, and at last the conclusions. The first case, a 70-year-old woman living in isolated rural community develops increasing abdominal discomfort, lost approximately 3 kilograms of weight over last 2 months, and develops severe nausea and vomiting, and inability to maintain adequate oral intake. So the family's access to transportation is not nearby hospital anywhere in that area. And over the course of the next few weeks, the woman again develops increasing amount of such similar symptoms of abdominal pain, poor appetite, loss of weight, and intermittent nausea and vomiting. So she is fortunate that a mobile health clinic was nearby to her place, and the nurse practitioner done an examination on her. It has shown that she has cachexia, enlarged tender liver, and dehydration. So she suspects that the patient is dying from an unknown gastrointestinal primary with extensive intra-abdominal meds, The family and the patients are provided with explanation of the suspected diagnosis and prognosis. Morphine and bisacaril added in prescription. Morphine for pain and to relieve from constipation related to morphine, bisacaril. So how to rehydrate this patient? Another case, again, a 70-year-old woman who was having increasing amount of abdominal discomfort, but she is from a wealthy living family, from a countryside. So she has been active and in good health, although she knows that she has lost approximately 3 kilograms of weight over the last few months. An extensive diagnostic imaging and subsequent liver biopsy confirms the pancreatic cancer with liver mets. She develops severe nausea, vomiting, and presents to the emergency department of our local hospital with clinical evidence of dehydration. Again, in this case also, oral morphine and bisacaril added. So, how to dehydrate this patient? Again, for this case, the second case, over the next few weeks, increasing abdominal pain required escalating morphine doses to achieve good control, and the patient expresses a preference to remain at home as she deteriorates. However, the patient and her husband indicate to the family physician that their religious belief are that everything possible should be done to maintain life for as long as possible. And intermittent nausea and vomiting resulting in an oral morphine being changed to the subcutaneous route, and increasing abdominal pain also required more morphine for her. Eventually, she developed delirium due to dehydration and increased morphine dose. So it became impossible to do IV cannulation on her. At this situation, how to rehydrate this patient? We'll discuss about these two cases after having short discussion on the topic of dehydration in palliative care. And again, come back. So, for introduction, artificial nutrition and hydration is a topic well known, is a common short-term intervention to support patients with reversible causes of nutritional deficiency resulting from temporary inability to eat or drink. Now, its risks and benefits are less clear for patients with serious chronic illnesses, particularly those near the end of their lives. So, but what happens generally, we consider the artificial nutrition and hydration together as a single thing. But actually, this causes unnecessary confusion, as the arguments and rationale for providing nutritional calories by artificial means as opposed to hydration should be considered independently. So in this presentation, we are going to discuss independently about the hydration in palliative care or terminally ill patients. So there are some basic terminology we need to understand. First, terminal illness. A terminal illness is an illness or condition which cannot be cured and is likely to lead to someone's death, and it's sometimes called a life-limiting illness. Palliative care is an approach that improves the quality of life of patients and their families who are facing problems associated with life-threatening illness. It prevents and relieves suffering through the early identification, correct assessment, and treatment of pain and other problems, whether physical, psychological, or spiritual, according to WHO. So this is the WHO guideline, when and how to provide palliative care to a patient. So it starts from the diagnosis of a disease. It slowly increases and even stays even after death of the patient. So you can see here my cursor. Can you see my cursor here? So who states that the palliative care affirms life and regards death as normal process. Neither hastens nor postpones death, and provides relief from pain and other distressing symptoms. Basically, maintain or improve quality of life and control symptoms. Why this slide is important for us? Because we are going to discuss about a symptom in terminal life or in palliative care where the patients having in terminal illness. So it's a symptom we need to understand first why we should do this way. Why we need to understand about the symptom first. So dehydration results when water losses from the body exceed water replacement. The loss of the body of water without sodium causes dehydration. Water is lost from skin, lungs, gastrointestinal tract, and kidneys. When the balance between water loss and water replacement hampered, then there will be dehydration. But there's slight difference between fluid deficit and dehydration. We are going to discuss about that right now. So this chart is taken from Eduardo Bruera's book, and we can see that fluid deficit is divided into two parts. One is volume depletion and second is dehydration. And we can clearly see that dehydration is always hypernatremic, whereas volume depletion may be hyponatremic, isotonic, or hypernatremic. What does it mean? We are now going to learn about this thing. So fluid deficit is the state of water loss with or without electrolytes, which includes the subtypes of volume depletion and dehydration. Whereas dehydration should be understood as a total body water deficit that is predominantly intracellular and associated with hypernatremia. Volume depletion implies a deficit in the intravascular fluid volume and can be isotonic, hyponatremic, or hypernatremic. So volume depletion is three types: hypertonic, where more H2 is lost, like in case of fever, increased respiration, or diabetes insipidus. Volume depletion may be isotonic, where both sodium and water is lost, like in case of vomiting, diarrhea, sweating, burns, intrinsic kidney disease, hyperglycemia, and hypoaldosteronism. And it may be hypotonic, where more sodium is lost, like in case of diuretic use. So rehydration is the process of restoring the lost water in dehydration to the body tissue and fluids. So it may be through different routes, like through oral route, through intravenous route, through subcutaneous route, through rectal route, or any other artificial pathway which created as there is any kind of obstruction in the normal pathway. Like if there is obstruction in the esophagus, we can try to put a Ryle's tube or sometimes gastrostomy. Those things are artificial pathway. So dehydration in terminal and palliative care, there are factors associated with fluid deficits. Like some of them are decreased intake, like anorexia, coma, delirium, dementia, depression, dysphagia, and nausea. In this situation, there is decreased intake. And there are some situations where there will be increased fluid loss, like in case of bowel resection, diarrhea, diuretic use, diabetes mellitus, fistula, fever or sweating, hypercalcemia, and vomiting. We'll come back to this slide again. First, how to assess the fluid deficit. So you need to think about, try to take the history of the patient, do a physical examination, and some laboratory findings. First, for the history, again, the previous slide, we can take history about these conditions. Like if the patients have a history of delirium, if the patient is taking orally taking less amount of fluid, is the patient having dysphagia or nausea, or the patient have any kind of history of vomiting, diarrhea, use of diuretics, is he diabetic or not, these things. For physical examinations, symptoms of fluid deficits, we can see. First one is behavior and cognitive change, fatigue, thirst, nausea, and dry mouth. So these are symptoms. The patient will come to you and tell about these things. And there are some signs of fluid deficits like dry coated tongue, reduced skin turgor, postural hypotension, and tachycardia. And there is reduced jugular venous pressure, sunken eyes, reduced sweating. So, however, all of these problems need to be interpreted with caution as they can be associated with other causes present in aging, cachexia, advanced cancer, and side effects due to commonly used medications. Like morphine can cause dry mouth. So, you need to differentiate the dry mouth caused by morphine and inadequate oral intake of liquid like water. You need to ask the patient about the history properly, and you need to differentiate in between these two things. So, regarding lab investigations, laboratory evaluations can provide some helpful information in evaluating fluid deficits, but it obviously depend on the setting of care and whether such investigations are acceptable to the patient, family, and healthcare team. So, what does it mean? Basically, they are saying that these laboratory investigations are not available in each and every settings. Like a peripheral rural area have not these kind of facilities, and also if it's not cost effective, then a poor patient or a patient terminally ill who already have passed through severe diagnostic test, they can't afford this kind of investigation. So we need to think about that also. So the common finding present in volume depleted patients include elevated levels of urea, creatinine, plasma proteins, hematocrit, and sodium. Again, the elevated levels of urea, creatinine, plasma proteins, hematocrit, and sodiums are the common finding in case of volume depleted patients. Now, rehydration techniques in palliative care. So the best and most convenient route to correct fluid deficit is increasing or improving oral intake. But most of the time, in case of terminally ill patients, the oral intake is so much less that we need to find somehow other route. So in that case, most of the patients have an IV channel, IV cannula. We can say this is a parenteral hydration route, and there is also a type of route which is enteral. Whereas enteral nutrition is delivered through a tube to your stomach or the small intestine, like a Ryle's tube. And parenteral nutrition is bypasses entire the digestive system from mouth to anus. So it directly, if we put the fluid to IV intravenously, so it will bypass all the routes. So this is parenteral route. So just I'm showing here how that it differentiates from enteral to parenteral. So for parenteral hydration, you need to think about type of fluid, volume, how much you want to give to the patient, and route of administration. So IV hydration is the route of choice in acute care. Like whenever a patient comes to a hospital, they try to achieve a IV route access through which we can use most of the drugs. But in palliative care settings, there are some disadvantages, like difficulty finding venous access. Most of the time, the patients are cachectic. Most of the time, they are weak. They are not taking any kind of oral fluid. they are old, so there will be increased difficulty finding venous access. There will be pain because multiple times they have tried to do IV route, and they are generally chronically ill. So multiple times they have punctured. So it will cause infection and limitation to mobility. Because if someone has attached a cannula, IV cannula, he need to remove it and then he can go to bathroom, toilet, wherever he want to go. And dispace lines, particularly with confused pain. Sometimes delirious patients try to tear it down. So that's another disadvantage. So another route is through subcutaneous route, and the process is hypodermoclysis. Subcutaneous injections are administered into the adipose tissue layer just below the epidermis and dermis. It's much easier and less painful, much less risk of infection and other complication. Easy to use at home and gives patient more freedom and control, and eliminates need for painful frequent IV injection. So in case where it's impossible to achieve an IV line, you can place an subcut route, and we can place in these areas where in this picture you can see in the abdomen, the lateral aspect of lower part of the upper arm, posterior aspect of upper arm, back, lower loins and thighs. There are some advantages and some disadvantages of subcutaneous route. Advantages can be used for intermittent or continuous infusions. Constant plasma levels can be maintained. Avoid first plus metabolism. Less danger of overhydration. Avoids problems secondary to continuous IV fluids like edema, ascites, pleural effusion, pulmonary congestion. And the disadvantages like clinical limitation in case of infection. So infection may happen, but it's less. Some medications treatments cannot be given through subcutaneous route. Severe thrombocytopenia, severe edema. In these conditions, we can also give subcutaneous route fluid. So for subcutaneous route, the infusion regimen is maximum continuous infusion rate up to 100 ml per hour. Maximum infusion volume usually 2 liters over 24 hours with a maximum of 1.5 to 2 liters at any one site. Maximum bolus dose 500 ml over 1 hour. The infusion may be given continuously overnight in boluses of 500 ml per hour, 2 or 3 times each day, with or without hyaluronidase. Now, the internal hydration, gastrostomy and nasogastric tube mainly for nutrition. Generally, for nutrition purpose, these things we generally do, and then it will help later for hydration purpose also. So nasogastric tube are generally uncomfortable for patients, and prolonged use cause more discomfort at the throat. So particularly in palliative care population, and should be avoided where as possible. Percutaneous gastrostomy are commonly used with head and neck or esophageal cancer patients with increasing dysphagia, who may benefit from nutrition as well as hydration. There is another route, it's proctoclysis. That means it's through a enema, you can put water into the rectum. In resource-limited developing countries where there are no that much resources, then we can safely, effectively put a tube on the rectum and use tap water for rehydration in this method. Because there are multiple blood vessels at the rectum, the water is slowly absorbed from there. Now, monitoring hydration is important because overhydration causes new symptoms. So how can we monitor hydration? Through urine output, blood pressure, mental status, subcutaneous sites like any kind of reaction or infection, and ensure no overhydration again. So benefits of rehydration in terminal and palliative care. It improves quality of life, provides relief from distressing symptoms of dehydration like delirium, fatigue, hallucinations, myoclonus, restlessness, confusion, neuromuscular deficits. There is no need to decrease opioid doses in terminally ill patients if we are providing enough hydration. Enhanced alertness and interaction. Now, the risks or challenges of dehydration in terminal or palliative care. It can easily cause fluid overlap, causing peripheral edema, shortness of breath due to pulmonary edema, bronchial secretions, increased discomfort, prolonged dying process, nausea, urinary frequency, bladder distension, and you need to put a catheter again for monitoring. Now, the decision-making process, whether to rehydrate or not. We need to consider some points like informed consent from the patient or their guardian, whoever is taking care of main caregiver. Cultural, religious, psychological, and emotional factors, and patient's wish and values, family's input, and medical assessment. These all things all together affects the decision-making process. So for surrogate decision making, this chart also taken from Eduardo Bruera books, and we can see there are triggers for discussion. So there are always some kind of trigger to start a discussion, like any kind of symptoms. Like in this case, for dehydration, there will be swallowing difficulty. So whenever a patient come with dysphagia, odinophagia, they couldn't swallow solid or liquid or both, then there will be food refusal, feeding difficulty. In these cases, and also in case of chronically ill cancer patients who are terminally ill and in end of life care, there will be less and less intake. So common expectation will be to prolong life. Why they are trying to get the hydration for this kind of patient? To prolong the life. 90% of cases, it's to prolong the life, to improve the quality of life, to give some amount of comfort, less choking, less hunger or thirst, this kind of things. Reasons for refusal may be poor quality of life, food refusal, water refusal, and if there is any kind of advanced healthcare directive. So this is a decision guideline to withdraw or withhold artificial nutrition and hydration, but we can consider this chart to guide ourselves about hydration also. Like at the first one, we can see we need to establish clinical facts and disclosures. Establish pertinent ethical and legal issues. Autonomy means the patient's wish, and maintain integrity of healthcare professional. All these four will ultimately help to establish ethically defendable consensus to withhold or withdraw nutritional support or hydration support. So this is a article review about decision making of artificial nutrition and hydration for cancer patients at terminal stage. It's a systematic review of the views from patients, families, and healthcare professionals. We can see that the background is decision-making on nutrition and hydration for cancer patients during terminal stage, causing critical impacts towards patients' comfort and living quality. And the management of nutrition is the main dilemma that arises in this final situation, has been subject of intense debate over the last few decades. The aim was to find about the views. Now, the result shows most of the terminal stage cancer patients and their families initially started the decision-making process when facing the reduction of oral intake. We already discussed about this. There are two primary considerations of patients and families. One is for prolonging patients' life, and the other is to maintain their life quality. The voices of patients are influential but not determinative. Families usually had influence, but seldom makes the final recommendation by themselves. Healthcare professionals frequently face the dilemma about their decisions. The conclusions, the decision of nutritional support was dynamic. The interaction between patients and families frequently be hesitated to protect the rights of life, unnecessarily prolonging lifetime. Therefore, a better understanding of the views on nutritional support and processing the clinical guideline of decision making for healthcare professionals is necessary. So there is not clear-cut guideline how to rehydrate a patient in case of terminally ill or in case of palliative care settings. And this makes controversies. So the next point is legal and ethical consideration regarding this. Is there any kind of advance directive for the patient? Is there? Is the ethical principles we need to remember while rehydrating a patient or choosing not to rehydrate the patient? And it's a balancing act. 3 points. So first, the cardinal principles, we know that autonomy means self-determination. The patient has a right to choose with what should be done with his body. Beneficence, do good, non-maleficence, minimize harm, and justice, fair use of available resources. So whenever we are thinking about rehydration of a terminally ill patient, we need to think about these 4 principles as a palliative care doctor. Now, there are 3 dichotomies to be balanced. The potential benefits of treatment versus potential risks and burdens. Striving to preserve life, but when the burdens of life-sustaining treatments outweigh the potential benefits, withdrawing or withholding such treatments and providing comfort in dying, and individual needs versus the need of the society. So these 3 points again, I think is the most important in taking a decision about rehydrating a patient in terminal care. We need to balance in between these 3 things. Now, decision-making process is influenced by patient and family's attitudes, level of comfort with the situation, and education and healthcare workers' attitudes. Level of education and biases in presentation are influenced. And the main determinants for rehydration are the patient's performance status, PPS score, fluid retention symptoms. Is there any kind of fluid retention symptoms like local peripheral edema, denial, and care receivers believe about the effects of dehydration on patient's distance? How much the caregivers understanding about this situation? Now, factors influencing caregivers includes symptom distress issue, ethical and emotional considerations, and information exchange between health professionals and families, and culture. Now, the controversies. So there are some arguments which are against parenteral hydration, and there are some for the parenteral hydration. Arguments against parenteral hydration are symptom distress is not experienced by comatose patients. Dying is prolonged by parenteral fluids. There is less urine and thus less problem with incontinence and catheter use in case of terminally ill patients. Decreased gastrointestinal fluid associated with dehydration results in less nausea and vomiting. Decreased respiratory secretions will result in less cough and pulmonary edema. the severity of edema and ascites is decreased in case of not rehydrating a patient in terminal care. Dehydration can act as a natural anesthetic for the central nervous system. So there will be less pain if you are not going to rehydrate a patient. And parenteral hydration is uncomfortable and limits patient's mobility. So what are the for parenteral hydration? There are some arguments. These are parenteral hydration assists in making dying patients more comfortable. There is no evidence that parenteral hydration prolongs life. Fluid deficits can cause restlessness, confusion, and neuromuscular irritability. Oral hydration is provided to dying patients complaining of thirst, and therefore parenteral hydration should be an option. Emphasis on the poor quality of life of palliative care population detracts from the efforts to improve comfort and life quality. Parenteral hydration is considered a minimum standard of care, and withholding parenteral fluid from palliative care population may result in withholding therapies to other compromised patient groups. Now we are going to discuss about some hydration studies, and we'll see that these arguments against and for rehydration in terminally ill patients or in palliative care settings, how it's evidence-based, how it's like, is it, should we give it or not? We are going to see about that. So researches into this use of hydration in palliative care settings has focused on three dimensions. One, the association between biochemical findings and hydration status, the association between biochemical findings and clinical symptoms, and between hydration status and clinical symptoms. So basically three things: biochemical findings, hydration status, and clinical symptoms. Now for the biochemical finding and hydration status, dehydration is a cause of renal failure, is proved. So there are multiple articles that says that dehydration is a cause of renal failure. So we should rehydrate a patient if we think about that. Most of the doctors who are not in palliative care settings, they prefer this point to rehydrate the patient. And the impact of fluid deficit and rehydration on the renal function and electrolyte balance of palliative care population is questionable. And third point, relatively small amounts of parenteral hydration may result in less abnormal biochemistry, particularly with regard to renal function in terminally ill patients. Here, this is a comparison between two different studies, one of which have given oral fluid, like in number 47, Ellerso et al. This one, they have given oral fluids, sips of oral fluids to patients, and another, those receiving hypodermolysis. So they are given fluid through subcutaneous route. So they have compared the urea creatinine level, and you can easily see that in this study, 47, they have given oral fluids. So the normal range of urea is 2.5 to 6.5 in this case, and the mean was 15.5. Whereas in case of subcutaneous route, there is mean 8.8, which is close to the range, 3.2 to 8.2. Again, for creatinine, you can see that for oral sips of water, 60 to 120 generally the normal range of creatinine in this study, and the creatinine shows high, 177. Whereas in the case of hypodermolysis, the 62 to 133 is the normal range, and the mean was 101, which is inside the range, normal range. So it shows that rehydrating patients through subcutaneous route at a terminal care actually improve the biochemical findings. Now, there are biochemical findings and hydration status versus clinical symptoms. How we can compare them? So there are multiple studies, but they are actually, if we consider them together, they are actually inconclusive. Like we can see here, Barge et al. They have done a cross-sectional survey and about studying the quantitative assessment of the dehydration experience in patients with advanced cancer. The study concluded that parenteral hydration on the basis of fluid intake and laboratory measures were not helpful if the aim was to reduce thirst. McCann et al. They are telling the symptoms of hunger, thirst, and dry mouth were apparently well managed with oral sips and mouth care. Elerso et al. They are saying that no significant association was demonstrated between the level of hydration and respiratory tract secretion, thirst, and dry mouth. Musgrave et al. They are saying that no relationship was demonstrated between level of thrust, intravenous fluid, and biochemical parameters. Another study is showing that failed to demonstrate any relation between intravenous fluid balance, and the prevalence of crepitation, ascites, and leg edema. There is another study where they shown that changing pattern of agitated, impaired mental status in patients with advanced cancer, association with cognitive monitoring and hydration, and opioid rotation shows the routine cognitive assessment, opioid rotation, and hydration may reduce the frequency of agitated confusion in terminally ill cancer patients. This one, one second. This one is showing that they concluded that morphine metabolites may be a causal aggravating factor in nausea and vomiting and cognitive impairment in palliative care patients with significant renal impairment. So if there is significant renal impairment, there will be increased risks of different symptoms like nausea, vomiting, and delirium. Lawlor et al. Showed that they, although delirium is multifactorial, hydration using hypodermoclysis may be one of the potential useful measures to consider. Another one by Bruera et al., the first randomized controlled double-blind study of parenteral hydration in terminally ill cancer patients. It's a multi-center study, showed that the outcome measure were patient and investigator-rated symptoms of fatigue, sedation, myoclonus hallucination, and global sense of well-being. Is significant improvement in sedation and myoclonus scores was noted in the hydration treatment group. So those who are getting hydration, they have significant improvement in myoclonus score and sedation score. A review by Birch concluded that there is little clinical evidence to guide patients, families, and clinicians in treatment decisions regarding fluid intake during the terminal phase of life. And a Cochrane review updated in 2014 concluded that there was insufficient quality research for practice recommendations in the use of alternative hydration assistance for palliative care patients. So after discussing about the topic, now we are going back to the case vignettes. And if we remember that the first case was about a old aged woman who was from a village or remote accessed area where there is no facility to like tertiary healthcare center. So we discussed about the patient is having some kind of GI tract cancer, which is late stage, and she stopped taking fluid and nutrition through mouth almost. But how to offer dehydration in this case? So NARS offer different ways of dehydration in that case for a variety of reasons, including economic and the increased burden this would place on the family caregivers. All of these options are rejected through IV route, through hypodermoclysis, through proctoclysis. All those routes are rejected because the caregivers couldn't like take this much burden because they are from a remote area, and if we need to regularly rehydrate, we need to monitor the patient. So they couldn't take the patient to a tertiary care center, and the patient's condition was not that much good. So they rejected all the options And instead, the family is given suggestion to assist the patient to continue to drink as long as this is comfortable for her, as well as some suggestion to provide mouth care. So the nurse suggested that if we are not giving any kind of fluid through any route, at least we can try to make her drink if it's possible. And to do that, you need adequate oral care. So the patient is in end of life, and the non-verbal communication in the room indicates that all of them understand that the nurse practitioner does not really expect to see them for a follow-up visit. Again, for the second case, we have discussed that a same-aged old 70-year-old aged lady who is from a city and have all the facilities and also diagnosed early about the cancer. She was having difficulty she was having dehydration symptoms. So how we are going to rehydrate her? So the most common method in case of acute settings is intravenous fluid, through intravenous fluid. So whenever a patient comes or goes to a hospital, they put a IV cannula first. So we can think about that. The rehydration with intravenous fluid will be possible for that lady. And the second question, when there was no option to do any kind of IV cannula, how to rehydrate her? So then we can do a subcutaneous route. That means through hypodermolysis. And how much we can give? 1 liter we can give overnight. That which kind of intravenous, which kind of fluid we can use? We can use normal saline or 5% dextrose. And in this case, they have added haloperidol subcutaneous route to reduce her delirium, and which ultimately subsided. So hypodermolysis for control of dehydration in terminal stage cancer. This is a clinical trial, and the abstract showed that randomized comparative and prospective trial to determine the usefulness of hypodermolysis in the control of thirst, chronic nausea, and delirium. They are using 1000 ml 5% dextrose in water infusion plus 140 milliequivalent per liter sodium chloride at a rate of 42 milliliter per hour per day. And the data suggests that decisions on rehydration of patients with terminal phase cancer should be based more on the patient's comfort than on providing optimal hydration. So again, they are giving stress on this point that the patient's comfort is the first priority. So at the conclusion, we can say that this is a complex topic and had been widely debated and controversial. And irrespective of the setting and circumstances, is a desire to keep the patient as comfortable as possible while avoiding unnecessary management or procedures is the main goal. And however, there is no doubt that the definition of unnecessary will have great international variation. The clinician with responsibility to make these decisions will need to sort through different things like expression of opinion. You need to properly express why you are going to rehydrate, and if you are not going to rehydrate, then that's also expression of opinion is important. Second point is information on pathophysiology and biochemical change. You should talk with the patient if he can understand, and with the attendants about the pathophysiology and biochemical changes. If you are not providing any kind of hydration, or if you providing, what will happen? You need to clear cut tell them about these things. Research looking at a variety of outcomes, we can show them different outcomes because we can see that there are multiple studies that some of them are against, some are for dehydration. So we can show them this research and differing family and cultural expectations. So there are different family have different expectations. So you need to understand that, and then you can then you can think about a solution. And the last point, consensus statements. So this diverse information then has to be individually applied, the point to be noted, to the specific trajectory and circumstances of patients and their families. Each and every point you need to understand here has to be individually applied to the specific trajectory and circumstances of patients and their families. You need to understand their families. Because at the first, where we started the slides, we discussed that palliative care is not only about the patient, is also about their family members, the caregivers who are continuously caring the patients. So you need to think about them also. Now, the key learning points, sir, hydration in palliative care is a controversial topic with divergent opinions. Fluid deficiency can cause confusion and renal failure. Hydration research is inconclusive in guiding clinical care. Hypodermoclysis is an excellent alternative for rehydration in palliative care populations. Diverse clinical and sociocultural circumstances need to be considered. Evidence recommends that if terminally ill patients are not rehydrated, medications should be decreased to avoid accumulation and side effects like morphine. And rehydration may be helpful in some individual situations. Patients and family preference need to be understood and incorporated into the treatment plan. Again and again, patient and family preference. So these are the reference I used. Eduardo Bruera, IPC, and hospital-based palliative medicine, and some research articles. And thank you.
Thank you very much, Dr. Ritabrata, for a very comprehensive overview about rehydration in end-of-life care and its controversies and benefits. So I really like the way you started with the definition, defining where it is required and how it can be given, going on to later on with the controversies and evidence, and also looking, showing us some hard evidence about for or against it, and also then coming with some conclusion. Thank you very much, Rito. So we'll take questions, and I'll start with Dr. Reena's comment. I request Professor Reena George to, can you just speak about what you just wrote in the chat box? Professor Reena George?
Just trying to unmute.
Yeah.
I just was quite impressed by the Bruera paper, which came out in 2013, where it was a double-blind randomized trial where, one group got 1 liter hydration, the other had an equally weighted bag where this dummy was put in. And their final conclusion was that neither the symptom score, nor the survival, nor the quality of life was significantly different between the two groups, not the biochemical parameters. So that is actually good evidence for supporting our default policy, which is, no knee-jerk routine hydration. But in situations where, it's more of dysphagia, or where there's a family goal, or there are specific reasons why we might hydrate, but the default position of not giving everybody hydration, the Bruera paper is very supportive, and it was a very well-conducted RCT.
Yeah, absolutely. Even I remember reading this paper quite some time back. The problem is that this is a very conclusive document which can help us most of the time in our clinical practice. But just let's understand that evidence is very little and hardly no research done in, I think, very little in our population. And so we really need to look at it now. More and more academic and research-oriented institutions coming up. I think it's time that we look at it from our point of view. We have some senior faculty here. I want to hear from them also, and on all others who are practicing palliative care and their how do they deal with it, and what are their reflections.
Hi, Gayatri. This is Shobha here.
Hello,
Good morning.
Go ahead. Shobha.
Can you hear me?
Yes, we can.
Hi. Yeah. Okay. So, excellent presentation, Dr. Rito, and well covered. What I just wanted to say is that we do give fluids. Like if the IV cannula is there, we sort of continue with that, and maybe not a liter when they are in the actual end of life stage, but 500 ml over 24 hours, very slow. And if the IV cannula is not there, as mostly the case is because of collapse or no IV access per se, or the patient is a little delirious and the IV line has come out, then we would say, okay, subcutaneous infusion. Again, we kind of look at if is a patient is likely to get overloaded with fluids, and then probably stick to 500 or at the most 1 liter. And we would encourage the patients by standard of water to these patients. So the other thing that I had is there a controversy in giving dextrose subcutaneously? That's what I wanted to know. Because normally we would give normal saline, but what about dextrose? It was mentioned in the last slide. So I just wanted to know what everybody's views are.
So Ritu, you want me to help? Yes, go ahead.
As much as I read about this topic, I think there is not like it's not to be given. They are trying to tell that if we have to give any kind of if we have to give fluid to rehydrate a terminally ill patient, it will be much more safer in subcutaneous route, and the how much amount and which type of fluid, it depends and varies for each and every patient. Again, it's not like written anywhere that is the guideline it to be given for each and every cases. Again, I am whatever I have read about this, they are telling that you need to individualize the treatment for each and every patient.
Thank you, Ritu. I think what the correction I want to do, just want to highlight, and thank you, Shobha, for raising this important.
Yes, thanks, Ritu. So that's yeah. Sorry, Gayatri, go.
No, I think I just want to correct. 5% dextrose by itself, normally we don't use for correction of this is not a crystalloid. And so we need to be mindful of that. This is not the crystalloid, so that alone should not be given. What we do is normally combination of normal saline with dextrose, because intracellular dehydration is corrected by facilitated diffusion. So sodium, when sodium has to go in, you use glucose. That's the reason we combine dextrose with normal saline. By itself, dextrose is 5% dextrose is not recommended. I think
So
we don't.
Gayatri, I think we have only 1 minute. We have to finish it.
So
Because,
I'd like to, yes, I'd like to conclude. Excellent presentation, Ritu. Sorry, like we can't take more questions. Just want to say, highlight two things here. Whatever we are doing, we have to remind ourselves about the goal of care to ourselves and to our patients when we make this consensus decision. It has to be shared decision making. Reminding ourselves what is the goal of care. It will help us to really make some hard decisions. Second thing is, Ritu, which we did not mention the presentation, is documentation. Let's remember that we have every step, whatever we decide in terms of shared decision making, it has to be documented, and that's something we had to be very emphasize. I want to emphasize on this aspect that please document whatever you do. So these are two take-home messages. Sometimes we do see controversies. Then sometimes sometimes time-bound interventions we do, and then again show the family that it's not effective before we finally withdraw. It is a very sensitive.
Thank you, Gayatri. It's 7:30. We have to stop. Thank you very much, Ritu. Seeing your presentation, I'm really happy that young palliative care physician in their middle of first and second year of residency, they giving such beautiful presentation. I think this shows that we are growing and the future of palliative medicine is great in this country. And again, the same thing, that evidence are enough that it does not help, but we have to individualize on this to case basis. But definitely this should be in our mind that the hydration in the terminal stage is not going to be helpful for the patient if it is truly a terminal stage. So defining terminal stage is very, very important. Thank you very much, Gayatri, for mentoring such beautiful residents in MNJ Cancer Institute. And thank you, Ritu, for presentation. And we have to stop here and see you next Monday before 6:30. Please join before 6:30. Thank you very much. Thank you, Archana. Thank you, Nisha. And thank you everyone for joining and for giving your comments. Thanks a lot.